I think we're about ready to start. So I'd like to welcome everyone to the 2024 Edinburgh Parkinson's Lecture. I'm David Melton. I'm the one who's been bombarding your inboxes with thousands of emails. It looks like it's worked. We have a very good audience here at the Royal College of Physicians of Edinburgh, and 1,100 people have registered to watch online, and I hope many of them are watching. I'm going to introduce Dr. Alison Williams, who is going to in turn introduce this year's Edinburgh Parkinson's Lecturer. Alison is an author, a poet, and a person with Parkinson's. And her introductions or concluding remarks at these events have become very popular. So I think you won't be disappointed. Alison.
That's called no pressure, huh? It's a great privilege to introduce our speaker for the 2024 Edinburgh Parkinson's Lecture. It's the 13th in the series, and this evening we're in for a treat. Richelle Flanagan is a dietitian of over 20 years standing, past president of the Irish Nutrition and Dietetic Institute, researcher into the impact of diet on Parkinson's, creator of the app My Moves Matter that supports behavior awareness and change for people with Parkinson's, World Parkinson Congress ambassador, co-founder of the Women's Parkinson's Project, and research partner with the Ulster University at Coleraine on the gut microbiome study. She runs her own nutrition consultancy, working with and contributing to individuals, businesses, NGOs, sporting organizations, and education providers. She also, as the rather vulgar expression puts it, has skin in the game. Richelle was diagnosed with young onset Parkinson's when she was pregnant with her second child. We're in for a treat, as I said. Over the past few years, we've been introduced to a range of symptom modifiers, ways we can tackle our own Parkinson's symptoms, notably physical exercise of different kinds, cognitive and mental exercise, the brain as a muscle, use it or lose it, and the importance of social and community engagement. In my mind's eye, I see myself at a large buffet, piling my tray high with 4 different kinds of exercise and 3 different kinds of mental activities, and just enough room to squeeze in some social engagements, and oops, I've dropped an exercise. But what I personally have not picked up on until now is the foundation of it all, the underpinning I need to sustain my health, to keep myself healthy, diet, the simple and far from simple basis of life, sustenance for my whole body, and nourishment that supports all my symptom-modifying activities. Almost invisible, taken for granted. So it's a great privilege to welcome Richelle Flanagan, and we look forward to benefiting from her deep knowledge and skill, and learning from her attitudes and her self-awareness, because PD doesn't just stand for Parkinson's disease, it also stands for passionate dietitian. So, Richelle, welcome.
Thanks very much, Alison, for the lovely introduction, and thanks very much for everyone coming out for the talk this evening and for everyone online. I'm really honoured and privileged to be, I think, the first person with Parkinson's to do this lecture, I believe, and the first dietitian, so I'm privileged on both accounts. And hopefully number 13 is lucky for some. So I'm just going to kick off. So I suppose, to start off, with my own history, as I say, I was 3 months pregnant with my second child, and a patient came back to see me in my clinic, and when I wrote in the record card, I noticed that my handwriting was a lot smaller than it had been the last time I saw that patient 5 years prior, and I thought, oh, that's a bit strange. And then I tried to make my handwriting bigger, and I couldn't, and I thought, okay, that's really strange. So Googled, like everybody does, and micrographia came up, and the only thing that kept coming up with it was Parkinson's. And I asked for a referral to a neurologist, and of course when he saw me, he's like, you're a bit young, to have Parkinson's. And because I was pregnant, I couldn't get a DAT scan to confirm it until my daughter was born and breastfed. So I had to wait 7 months after she was born and have a DAT scan, and that confirmed young onset Parkinson's. So I suppose as a dietitian, when you're counselling people, you always say, you try and empower them, to connect with organisations, in relation to their condition, whether it's diabetes, in this case Parkinson's, and I, also to empower them in terms of giving them resources around diet, again, if they have cancer or diabetes. But I found a real lack of information about young onset Parkinson's, women with young onset, and then also diet for Parkinson's. So that led me to attend the World Parkinson Congress in Kyoto in 2019. And I was really excited, to meet other people with Parkinson's, particularly, again, young onset and potentially women with Parkinson's, and also to kind of, get loads of information about diet and Parkinson's. But I was sorely disappointed. There was very little. So it made me come home and actually research the area in depth myself, and I wrote this article for my professional body about the case for greater nutritional care, and that was back in 2019. And just to show you here, this is actually a picture from a friend of mine, Fiona Lithander, and her colleagues who wrote this paper. Some of you might know Emily Henderson. It was in relation to the Prime PD study that's ongoing, looking at nutrition in people with Parkinson's. But this picture kind of depicts the number of symptoms of Parkinson's and how they affect nutrition. So in terms of, for example, the tremor and dyskinesia, that's obviously going to increase energy burning, so weight loss. In terms of sarcopenia, that increases the risk of falls. Obviously, in terms of bone health, low bone mineral density, so I'm going to talk about osteoporosis. Obviously, worsening dexterity, so the difficulty in preparing food. And there's a whole ream of gastrointestinal issues that impact your nutrition. And also things like dysphagia, in terms of swallow issues, smell, taste, all of these things. And obviously then there's the cognitive, which I'm going to speak to as well. So what I did was I reached out to my old professor where I did my master's in dietetics years ago, the University of Ulster Coleraine. And I said to her, look, I'd really like to do a focus group, and would you help me with that? And we were looking to apply for a grant, so we said we'd do the focus group. And this was one of the questions: how does Parkinson's impact how you eat and drink? And the results were showing that people were saying that the non-motor symptoms had the biggest effect in terms of fatigue, apathy, concentration, cognition, planning, constipation, chewing, the dry mouth, smell and taste, swallowing, weight loss, impulse control. And then symptom fluctuations made preparing and eating meals difficult, and the need to actually plan around the fluctuations to actually prepare meals. And in terms of things like the constipation, the chewing, the dry mouth, the smell and taste and swallowing, all influence the food and drink choice. And obviously a big thing then is the medication and interaction with meals is a huge issue. And also what was raised was the social embarrassment of eating in front of others, when one has dyskinesia or tremor or drooling or whatever symptom it might be. And the last thing that came across very strongly was all of these things are much harder when you're living alone. Whether you're young onset, single, living with it, or whether you're older and lost your partner and living with it. So we asked then, what kind of things would you like to know more about diet, nutrition and Parkinson's? So top of the list was a personalised approach to diet for people. They want to know about supplements, prebiotics and probiotics, They wanted advice beyond the whole protein and medication interactions, looking at the different types of diets that might benefit people with Parkinson's. They wanted to be culturally specific, and looking at digestive and bowel issues, menopause and the hormones' effect on diet and Parkinson's, and basically anything scientifically proven to improve symptoms, and consistent advice they would like from different dietitians. So obviously, in terms, I'm going to try and answer some of those questions this evening, and one of the kind of core ones is, what diet should I consider following? And you can see there's a whole range of different diets. I just picked out the ones that are the most commonly asked about. And I tried to put together sort of a picture to sort of show which ones are more beneficial than others. And unfortunately, our current Western diet is the worst for Parkinson's. You'll see here in terms of the greens, the green light, the Mediterranean style diet and vegetarian diets are positive for Parkinson's. What I would say there with the caveat is the vegan one has to be very cautious about, because you can cut out a lot of nutrients that are very important for Parkinson's, and it can lead to an unintentional or intentional weight loss, which with Parkinson's we have to be very careful about, because malnutrition is a big issue in terms of weight loss. Sometimes people ask about gluten-free. I'm celiac myself, and whilst I have my own theories that perhaps it's played a part in my own Parkinson's, the evidence is not there at the moment to show that. And certainly going gluten-free is not necessary for people with Parkinson's. And one of the negatives of going gluten-free is that you cut out fibre, which is very important for Parkinson's, around constipation. And also in terms of when you cut out whole, gluten-containing foods, you cut out a lot of nutrients that are in those whole grain foods and gluten foods. So things like vitamin D, B vitamins, etc. And in terms of the low glycemic index, again, there's not really much evidence about it, but what I would say, it ties into the whole combination of blood sugar control with Parkinson's symptoms, which I'm going to touch on. The keto is a big one that people ask about, but what I would say is the studies are very small in the ketogenic diet, and there are big negatives in terms of weight loss and also nutrient deficiency and adherence. It's a very hard diet to stick to long term. And similarly in terms of fasting, again, the evidence is not strong enough there, and you have to sort of think about not doing harm to the person who's sitting in front of you and put into context what is the proper thing to do. So you'll see really the Mediterranean style diet tends to be the one that's coming out the highest. So this kind of gives you just a pictorial of the Mediterranean style diet, but there's also another diet called the MIND diet, which is a sort of a version of Mediterranean diet combined with the DASH diet, which is used for blood pressure control. So both of those are showing very good signals in terms of improving health in general, but being good for Parkinson's. So they have attracted attention in potentially reducing clinical progression of Parkinson's, preserving cognitive health, and protecting against depression. And it's shown that women who stick to the MIND diet, they have a later, 17 years later onset of Parkinson's when they stick to a MIND diet versus a normal diet. And for men who stick to the Greek Mediterranean diet, there's research to show that it delayed onset of Parkinson's by almost 9 years. And when you looked at the MIND and Medi, they do scoring of the quality of these diets. Both of these diets, when you follow them more, they lead to fewer patient-reported symptoms over time, so better symptom control. And with each MIND point being twice as strong as the Medi point. So it's sort of showing that the MIND, if you're like betting on a horse race, the MIND diet is slightly ahead, a neck ahead. So in terms of research that's showing the Mediterranean diet, there have been one randomized controlled trial that showed that adherence only in 35 patients, but adherence to the Mediterranean diet over 10 weeks, remarkably, is the word they used, increased executive function, language, attention, concentration, active memory, and total cognitive score. So a lot of these are the kind of executive function symptoms, which I think aren't always really spoken about much in Parkinson's. And then also, they sort of had a wider group of 70 patients, and it showed that it increased the total antioxidant capacity. So it's shown that the Mediterranean diet, in terms of the constituents of it, are shown to improve this antioxidant capacity, which helps to kind of dampen the inflammation that happens with Parkinson's. and can lead to progression. And also was shown to potentially lower the, we all know the UPDRS score, which kind of gives us an indication of progression. There was also a small study, it was very small, only 8 people, a dietitian in the US, Carly Rush, did it, looking at the Mediterranean diet and intervention, and it did improve constipation. It looked at potentially modifying the microbiome, but there was weight loss. And I suppose that's one thing with the Mediterranean diet. It tends to be a healthier eating diet, so you have to be careful that weight loss is not going to cause you more trouble. So that's why working with a dietitian, it can be adjusted to make sure that you're getting enough calories on such a diet. So Carly Rush reported in her paper that the average Medi diet, so that's a score of the quality of the where people following all the requirements of the Medi diet. So she showed the average score was 4.4. And then I did a survey of people worldwide, and in terms of their diet intake and compared it to this Mediterranean diet score, the average was 6 out of 14. So you'll see in terms of a score over good or very good is over 10, moderate to fair is 6 to 9. So we're not really doing very well at the basics of getting good nutrition in, which could make what I call low-hanging fruit a big difference to people's lives with Parkinson's. But you're not getting access to that information. I suppose just a consideration, one thing that often people ask about is dairy. You Google and it's dairy, associated with risk of Parkinson's. And there is a lot of studies out there that show an association, it's not a causation. And there's no study to show a risk of having dairy when you have Parkinson's, of it causing progression or anything like that. But this study, or basically systematic review, did show a potential dose sort of response that for every 200 grams increase in total dairy intake was associated with an 11% increase risk of developing Parkinson's. But on the flip side, it also was associated with a 12% reduced risk of cognitive impairment. And we know from research that dairy actually is potentially good for our cognition. So the whole sort of dairy debate, no one's actually got to the bottom of it yet, what is the cause, but potential reasons for the association with the risk are pesticides, uric acid, which is moderated by sort of diet, bacteria, the microbiome, and also recently maybe sugars in the dairy. And actually I was doing a lecture today with Queen Margaret College for their dietitians, their trainee dietitians, to kind of raise awareness around the need for education for dietitians around Parkinson's. And one of the lecturers was saying, I wonder about the dairy. So it got me thinking, I wonder if it's to do with the fats in the dairy and the different constituents. So I think this is where we need more nutrition researchers and dietitian researchers in to look at this from a different perspective than just a neurological perspective. One part of the Mediterranean diet is having a glass of vino. So generally speaking, it is red wine that they sort of would advise as part of the Mediterranean diet. But to sort of put this into perspective, like it's 100 mils. Now, I know in Ireland, no one pours himself 100 mils. So there's the kind of a balance here. But what's interesting in terms of, could you have grape juice instead? And certainly grape juice is going to be healthy for you as well. It has these, very powerful constituents, which are, again, antioxidants, the flavonoids. But actually, when you look at grape juice, they've a lot less than what's in the wine. So it seems to be something, within the fermenting process that potentially is going on within the red wine as well. So I'm sure lots of people be interested in getting involved in that research. So then in terms of supplements, people ask all the time about what kind of supplements. And I suppose I start off with the ones that are really important to consider. And calcium is one of those, because people with Parkinson's have a high risk of falling, and they also have a high risk of osteoporosis and osteopenia. So when I talk to people with Parkinson's, it's most of them have osteopenia or osteoporosis. So there's something going on in terms of metabolism with regard to bone health. So the other thing is vitamin D. So making sure that you're getting enough calcium and enough vitamin D into your diet is really important. And also you should be getting a DEXA scan to check your bone health, because you keep your bone health strong so that if you fall, you don't end up in hospital with a fracture, because we all know how it ends up in terms of, getting your medication on time. And people with Parkinson's actually are the biggest bed blocker out of all neurological conditions. They tend to stay in a lot more than stroke, than MS, etc. So you don't want that to happen. The other thing then is B vitamins are really important, and I don't think are being looked at enough for people with Parkinson's. So low vitamin B12 status is very common in early Parkinson's, and a low vitamin B12 status at baseline predicts a greater worsening of mobility. And also there's a thing, when you've low vitamin B12, there's a thing called homocysteine, which is raised in our blood, and if you have elevated homocysteine, it predicts a greater cognitive decline and a worse cognitive performance in women and a greater motor impairment in men. So you're starting to see maybe a bit of theme here as well with regard to sex differences between men and women with Parkinson's. And neuropathy, so neuropathy, you can see here the picture on the screen, is things like unusual sensations, pain from light touch, burning, numbness, tingling, balance problems, muscle cramping, twitching. Now, would you say they're quite similar to Parkinson's symptoms? All of those. So a lot of times people think that they may be progressing, but it could be potentially that some of their symptoms are actually to do with vitamin B12 deficiency. And neuropathy is very common in advanced people with Parkinson's when they're treated with more than 2,000 milligrams of levodopa. So that's when you're getting up to the 8, plus a day. And often it's due to low vitamin B6 as well. So there's risk of vitamin B12 and B6 deficiencies. Levodopa metabolism requires these. And really the papers would sort of suggest that there should be lifetime monitoring of B vitamin levels to address this problem. And there should be a more reliable strategy to prescribe these vitamins maybe from the beginning when you're starting levodopa. But I just wanted to kind of highlight in terms of a paper that was looking at vitamin B12 deficiency in general, not just in Parkinson's, but it was showing that actually doing blood tests isn't the best way to identify vitamin B12 deficiency. And in fact, normal blood levels of vitamin B12 might be normal for the normal population, but if you have Parkinson's and you have normal vitamin B12, that actually could mean that you're deficient. So they advise that really vitamin B12 deficiency should be taken on the basis of symptoms. But of course the difficulty is, how do you define between what's a Parkinson's symptom and what is a vitamin B12? So I think this needs to be looked at more. And generally speaking, when I talk to a lot of people with Parkinson's, they have issues and they're on vitamin B12 injections, which is the best way of dealing with these symptoms. And what's concerning for me is that neurological symptoms from vitamin B12 deficiency can take several months or several years to resolve completely. So how much is that playing into the cognitive profile of Parkinson's, and how much could we benefit from actually looking at that? And I think we need to do more research in that area. In terms of B vitamins, just to be a note of caution, people sometimes take high-dose supplements. If you take high levels of vitamin B6, for example, paroxetine, it can cause severe nerve damage and lead people to lose control of their body movements. In terms of vitamin B9, high folate can actually mask vitamin B12 deficiency. And in terms of vitamin B3, niacin, again, that can cause things like headaches, rashes, dizziness, etc. So you just have to be careful if you're taking supplements. You need to talk to your neurologist about it. Other supplements that are quite common, coenzyme Q10, I don't know how many people I've heard using this, and the evidence is just not there. And it's costly. And also if you're on warfarin, which many people may be with later onset Parkinson's, it can actually interfere with the warfarin, for example. The other thing then is mucuna pruriens, which is kind of the natural form of levodopa. And again, the research is, there's not great research there at the moment. However, when I was at the World Parkinson's Congress in Barcelona, it was interesting. There's a few papers where people with Parkinson's were presenting how they felt it improved their Parkinson's using this natural form. And actually, this is a quote from Professor Michael Oken. He has a great blog called theparkinsonsecrets.com. He's based in Florida in the States. And he sort of said that brittle Parkinson's disease is when very small doses of carbidopa levodopa, so quarter-half tablets, induce dyskinesia. So he feels that these microdoses of mucuna can actually potentially make a difference there. But it's very frustrating, he said, the available products are not regulated. and do not contain consistent amounts of levodopa. Is it safe? He said maybe, but actually depends on the formulation and the way it's prepared. And there's big sort of safety issues. And actually, when I was diagnosed first, I was trying to find multidisciplinary care in Ireland, and I couldn't, so I actually went to the Italian Therapy Centre in Italy, funny enough, and that was actually set up by an English man, and it was a fantastic centre. It's a not-for-profit, and I remember that there was someone there, I don't know what his nationality was, but he was taking mecanoprurins, and it was causing him huge negative impact because he was taking unregulated mucuna. The other thing then is N-acetylcysteine is something that's often talked about, and it's been used in certain trials using an IV oral doses as well, and it's shown that it improves Parkinson's symptoms, but again, we need larger randomized controlled trials, and a lot of these supplements can have negative impacts, things like blood clotting, lower blood pressure, etc. So then I'm going to get on to the whole medication and diet sort of side of things. So in terms of meal composition, what you eat impacts how well your medication is absorbed. So if you have a large meal with high fat and protein, that basically slows down your stomach emptying. So your tablet has to get from your mouth, down your esophagus, into your stomach, into your intestines, and then it goes into your blood, and then it has to get your brain. So there's a long journey there. And I suppose just one thing also is, before it even gets to the stomach, one of the problems that can happen, it can get stuck in your throat. So you think that, I'm not turning on, my medication hasn't worked. It could be that your tablet didn't even get to your stomach to start with. But when it does get to the stomach, if you've had a big meal, that tablet can stay in your stomach and it basically degrades and doesn't get to where it needs to get to. So that's why you can get these fluctuations and variations in symptoms. And then also protein timing is very important. So protein breaks down into amino acids, and those amino acids get absorbed through the stomach as well or into the intestines. But the most competition, those amino acids cross the blood-brain barrier at the same place as levodopa. So if you take your medication with protein, it could reduce the effectiveness of your medication. So this is one of the most simple things to change that can actually be quite life-changing for some people with Parkinson's. So the other thing as well, people often take their meds with milk or yogurt. So again, to trial that maybe without milk, but using water or say something like applesauce instead. Now there's a caveat there for people who have dyskinesia, which I'm going to come on to. So generally speaking, what we say is to try and even your protein requirements throughout the day. So if you have a big lump of protein in the middle of the day, you might find that your symptoms are more off during the day. And so also we find that when people are getting up to 6 doses a day, it's very hard to time your meds half an hour before your meal and an hour after your meal when you're taking medication 6 times a day. So one of the things we have know that can help is when you redistribute your protein. So if you have most of your protein in the evening time, then you take that protein out of the equation of being interfering with your medication uptake. So that has shown some positive effects. But there was one caveat: if you do take all your protein in the evening, you can be more off in the evening or at night time. So you might find it a struggle to move in the bed. So you might need something like dispersible Madapar to help in that situation. So the other thing then is in terms of the microbiome. A lot of people ask with regard to the impact on Parkinson's, and there are 2 particular bacteria that can affect Parkinson's, how well your medication works. One is called Helicobacter pylori, which is an infection of the stomach, and there's a big link between Helicobacter pylori infection and developing Parkinson's. And also, if you get it during Parkinson's, it can worsen your response to your levodopa, because it actually eats your levodopa. So it has a little meal for itself. And also then in terms of small intestinal bowel overgrowth, that's higher in people with Parkinson's. That's where you get an overgrowth of less healthy bacteria in your small intestine, and it can go into your large intestine as well. And basically that eats your levodopa too. Also in terms of these 2 forms of bacteria can interfere with your vitamin B12 absorption, your iron absorption, and your vitamin D. So there's a lot of impacts. So these need to be dealt with, and a lot of people with Parkinson's are not referred to gastroenterologists to, to investigate these. And also in terms of Helicobacter pylori and SIBO, there are a lot of bowel symptoms with them, so bloating, wind, diarrhea, weight loss. There's a whole range. And then in terms of, how do you counter that Helicobacter pylori and also the overgrowth of the unhealthy bacteria, is eating a healthier diet like the Mediterranean diet. And also you'll see here that basically a diet that's more Western actually causes more problems, what we call dysbiosis in this microbiome. And many people ask about it, say the prebiotics and the probiotics. There's a lot of talk about it. And there's some beneficial or studies that show benefits of probiotics to improve constipation. But in terms of actually improving the motor and non-motor symptoms, the jury's still out. We still need more results to show that that is the case. There's definitely a huge area in terms of the impact of these probiotics on modulating the microbiome in a positive way. But as it says there in a recent paper, while preclinical and clinical evidence suggests promising benefits of probiotics and prebiotics and PD, you need to be, buyer beware. And one thing I want to say to you is that it's shown in all the studies of microbiome in people with Parkinson's generally are very high in lactobacillus and bifidobacteria. And they are generally two bacteria that are known to be anti-inflammatory, so positive for our system and reducing inflammation. So why are they higher in people with Parkinson's? So one of the theories is that, that they've gone to the dark side and they've become, pro-inflammatory, but also in terms of, again, these bacteria feed on levodopa. So the more levodopa you have, the more bifidobacteria and lactobacillus you have. So it kind of becomes this vicious circle. And also there's a thought that maybe they're also proliferating because the body's trying to kind of counter the inflammation by, having more of these bacteria. So there's definitely a lot of potential in that area. In terms of weight really matters in Parkinson's. So in terms of, there's many papers to show the issue. Survey and asked people, had they lost weight, and 30% said they lost weight unintentionally since their diagnosis. And actually there's been a research paper looking at maybe a phenotype of person with Parkinson's in terms of having problems with smell, weight phenotype, or a smell weight dyskinesia phenotype. And it sort of concluded that weight monitoring and weight-orientated approach to management of Parkinson's patients should help to improve their outcome. And we know that weight loss appears to be associated with more rapid decline in motor function, cognitive impairment, disability, and mortality. The other thing about weight as well is that a lot of people with Parkinson's, and even myself included, I noticed my appetite is not as good as it used to be. And orexin is basically involved, it's a hormone involved in appetite and spontaneous physical activity. And its decrease in Parkinson's could contribute to a decrease in food intake and physical activity. And ghrelin, which is a gastric hunger hormone, is also reduced in Parkinson's and has been considered as a potential biomarker of the disease. But I'm not seeing too much research about it. And I think these are all areas that need addressing. In terms of dyskinesia, I have a personal bone to pick around dyskinesia, in that it is higher in women than men. Lower BMI gives you a higher risk of having dyskinesia, and women tend to have a lower body mass index, so that's your weight to height ratio. And there's a recent study that showed that women might require a 25% reduction in levodopa dose in comparison to men. So it makes sense. I'm giving 3 doses a day of 25 or 100 cinnamon, the same as a man who's 100 kg. How does that work? And it doesn't work. It doesn't work for women because we end up having more dyskinesia. The other thing is there's an enzyme called CONT enzyme in our bodies, and that basically breaks down dopamine in our body. But women have 30% less of it. So that means that we actually have potential to absorb more levodopa. So there's a number of pharmacokinetic things that are not being addressed in terms of the difference between men and women. The other thing is people with Parkinson's often suffer from slow stomach emptying, and it's to do with the Parkinson's itself, potentially to do with the levodopa, content and as you increase it. But basically it means that you start to feel full early when you eat. You can get nausea, vomiting, but actually some people don't notice the symptoms, but they notice that their Parkinson's symptoms are very erratic and fluctuating. And this can be because the tablet is stuck in your stomach and is not making it out. And so this is why a lot of people are like, I can't understand, like I'm just not turning on. And the thing about gastroparesis, it's 3, actually, and I read a paper, to 4 times more prevalent in women. And again, it is also impacted across by hormones, across the menstrual cycle and across perimenopause into menopause. So the thing about weight is weight gain. So in terms of overweight and obesity can happen due to impulse control disorders because of things like the agonist medication. It can happen with the levodopa, but it tends to be the agonists like Requip, pramipexole, things like that, and Nupro patch. In terms of eating disorders, are higher in people with Parkinson's than people without Parkinson's. Food addiction is higher again, and higher in women than men with Parkinson's. There's a substantial evidence to show weight gain occurs after DBS, and up to 12 months after DBS, people can gain up to 12 kgs, or 6 kgs. That's 12 pounds, like that's a lot of weight, and that can actually have a very detrimental effect for some people. And it's shown in some studies that in DBS, nutritional intervention has been shown to be effective and should be performed routinely. As weight gain occurs essentially in the first months after surgery, information and dietetic guidance of the patient should start before surgery. So it should be a bit like bariatric surgery. You see a dietitian before, who helps you, explains to you what's coming down the line, how to manage it. But I know very few people who get to see a dietitian for DBS. And actually there was a dietitian in, I think it was King's College or UCL, and she was saying there was one female patient who had DBS and she had put on so much weight afterwards, she said she wished she never got the DBS done. In terms of sugar, this is the big one. People always talk about cravings with Parkinson's. And there's a whole ream of risks in terms of why that could be. The impulse control, it can be due to things like REM sleep behavior disorder, where like your sleep is so fragmented that you are just completely fatigued and you're looking for energy. Depression, cognitive impairment, chronic pain, motor fluctuations, poor sleep and fatigue. The microbiome might be playing into this as well, and also hormone fluctuations. I think there's any woman in the room here who hasn't experienced cravings across their menstrual cycle when they had it. So the other thing then is in terms of timing of food, medication, exercise. So this is something I feel quite passionate about, is that there's a lot of focus on exercise being beneficial for symptom control and also potentially slowing progression. But actually the two combined together are showing that they actually are complementary and lead to better improvements in muscle force, UPDRS scores, mobility than exercise or medication alone. So back to Alison's point, it is the foundation, and I beggars belief that it's left out so many times. So what is the point in someone being put on an exercise schedule when they are underweight, they're not eating? You kind of need to give them the foundation to actually get the best out of that physical therapy program. But in terms of then timing of medication, so I talk to a lot of people and they might, be starting to go off and they decide to go and exercise and they're wondering why they're so fatigued. So it's important in terms of looking at your exercise as well, how your medication is timed in terms of your food and the timing of your exercise. So I'd love to see more research on that as well. In terms of the importance of diet to people with Parkinson's, we did a survey and 82% of people rated diet as important in their Parkinson's care. In terms of their knowledge, their self-rating, 35% said they had average knowledge and 25% poor or very poor. So they do consider, we do consider diet important, but the knowledge is lacking. And we asked then, what has been your experience of getting advice on diet and nutrition from the health services? This is what they said: complete lack of information provided by neurologists, lack of understanding of the importance of diet and PD by neurologists, complete lack of resources, lack of knowledge of dietitians of PD specific needs, and lack of referral to dietitians. So I actually approached University College Cork and said, do you have one of your students be interested in doing a study, a survey? So she did a survey of dietitians in Ireland to ask them their knowledge of Parkinson's, and it was fairly stark in terms of their lack of knowledge, except for the few who actually see people with Parkinson's. So they said the barriers to their provision of PD-related care was lack of education training, lack of multidisciplinary team inclusion, and lack of referrals. And they really said that they need more specific training, not just for them, but also education for the healthcare professionals too, to bridge that gap in access to dietetic services and enhance the quality of care for people with Parkinson's. And this is some of the sort of sobering comments that were made. I asked for a referral for a dietitian, and I was told by the doctor that I didn't need to speak to a dietitian. The neurologist's response was, move more, eat well. Neurologists don't have a clue and don't see the relevance of diet. No talk of diet by the doctors, info never provided. And also, in terms of dietitians, we have to put our hands up. Conflicting answers between dietitians, each giving different versions of advice. Need one message, so there's no confusion. The registered dietitians don't know about PD is off-putting. And it's really hard to hear, my people talking to me about, that they went to see the dietitian and, she wasn't great. And to be fair to the dietitian, part of that is because she's never been trained. And actually, Parkinson's is complex and it needs education of the dietitians to help you. Also, in terms of, we asked, were you referred to a dietetic service? 84% said they were never referred, and 87% they were never asked. 87% they never asked for referral to a dietitian. And that's a really important point. In the health services in Ireland or here, if you don't ask, you don't get, and the service will not be put in place. So you need to ask for it. There was also then studies to back that up. A small study in Belgium showed that only 11% of patients had ever seen a dietitian, only 3% on an ongoing basis. And I hope I've shown to you how important it is to see a dietitian on an ongoing basis. And recently, a nationwide study of 1,500 people with Parkinson's showed that only 15% had access to a dietitian. So this led me to co-author a paper on the role, the importance, the missing piece of the puzzle of dietetic care, nutrition care in the management of people with Parkinson's. And this shows you a whole range of areas that we are involved with people in terms of nutrition. And does nutrition therapy work? So this is just showing you one study that showed it was a 6-week nutrition intervention with a dietitian and nutrition nurse. They were given oral nutritional supplements if they were underweight. They were given a diet that gives them 30 to 35 grams of fibre. Their vitamin supplements were optimised, and they were put on a protein redistribution diet. They were on average age 60 to 68. Almost 70% had a normal nutritional status. And poor nutritional status affected depression and anxiety. And those with malnutrition and risk of malnutrition had more severe symptoms in all subgroups of the UPDRS scale, including mental, motor, and ADL and complications. The results, I think, were pretty astounding. A significant improvement in malnutrition score, a significant improvement in disease severity, quality of life, and nutritional status, and a significant improvement in their self-perception of health, and a decrease in depression and anxiety. And ultimately, the author said that nutritional assessment should be a standard approach in Parkinson's, although we need more research. Disregarding the nutritional features in Parkinson's theoretically worsens the disease process and quality of life. And this is, again, why I wrote this paper with two colleagues with regard to the protein side of things as well. So there's guidance that is not getting out there, both to health professionals and people with Parkinson's, as to how to manage and improve their symptom outcome. And as I mentioned there about the protein redistribution diet, I'm not going to go into the detail there, but it kind of gives guidance about how to do that. But ideally, you should be seeing a dietitian to help you with that, to make sure that you don't lose weight and that you get the right amount of protein, because protein helps to combat fatigue, is good for your immune function, prevents loss of muscle mass, which keeps your bones strong as well, and can help to make neurotransmitters. So you'll see here in terms of 55 kg woman, if you did a protein redistribution diet and you put most of your protein in the evening, it'd be about 33 to 44 grams of protein. And then I've shown you a picture here on the right-hand side of what, the amount of protein that is in different, sizes of chicken breast. And you can see actually, it's not a huge amount in terms of the size of a chicken breast. 8 ounces gives you 60 grams protein. So actually that's more than that woman's total protein needs for the day. And it's shown when people go over 1 gram per kilogram body weight of their protein, that actually the requirements of levodopa go up, which is what we want to try and avoid. And the issue is that, it's about quality and quantity. So these are quite typical Irish and English plates of food. So huge portions of protein, and this is going to have an impact on how efficacious your medications are. So just going to sort of coming to the end here. There's a paper just written very recently. It was actually Silke Creswell, and she spoke at the WPC in Barcelona, and they're doing some great work in this nutrition and diet space. They're actually doing a trial in the combined Medi-Keto diet. But this paper sort of said that Parkinson's intersects with nutrition on numerous levels, both pathophysiological, motor and non-motor symptoms, medication interactions, the disease course, quality of life, and also socioeconomic determinants of health. In terms of, diet is a big part of our lives, and cost is a big aspect of it as well. So there are many issues. So ultimately, this paper sort of said that nutrition therapy is central to the health of people with Parkinson's. We need nutritional guidelines that are consistent. We need training in nutrition for medical students and physicians so they don't dismiss people when they ask about it. And we need access to dietitians trained in Parkinson's. This is about empowering people with Parkinson's with a generally low risk but potentially crucial self-management tool. And I just want to finish in terms of my colleagues. I'm very grateful for them in the University of Ulster, to my professor, Helene McNulty, my old professor, when I did my master's there. And when we didn't win a few grants, she was like, we are going to get a study for Parkinson's. And we've got one. So we are actually, it's just been approved, and it's basically testing a novel functional food. And we have a Kieran Toohey from the University of Leeds, who's going to be assessing the microbiome. And so they are currently recruiting in the north of Ireland. So if anyone is interested or knows anyone in the north of Ireland, the email address is there to make contact. So thank you very much for your attention.
Professor Thilo Kunath is managing this as expertly as usual, I expect, and he's going to juggle between questions from the auditorium and online questions. Over to you, Thilo.
Great, thank you, David. So it's a great pleasure to host the Q&A. Richelle and I have had a really excellent day. So I'm Thilo Kunath from the University of Edinburgh. So there are some roving mics around. I think there's 2. And also, if you want, there's also mics here that you can press the button, and when you press it, it comes back on. Yeah. So I'm going to ask for some questions from the floor first, and I have a lot online. Yeah, please.
I feel it's like countdown.
Thank you, Richelle. That was really, really interesting. So much so that I would like more time to process it. And it was just a request, and I know I won't be alone. I've seen lots of people taking screenshots and notes. We'd love to see your slides and have access to them.
Yeah, no problem. I said that.
Superb.
No problem, yeah.
Yeah, so I should have said at the beginning that the whole lecture is recorded and will be available on YouTube. And I think the slides will also be available through David Melton, which is great. So you can...
Sorry, we put the slides onto the branch website, and I can do that in the next couple of days. The recording will take a bit longer to make available to everyone. But anyone that's registered, either here or online, will get a link to watch the recording as soon as it's available.
Okay. Question? Okay.
Thank you for an excellent presentation, Richelle. Just a question about one of the supplements you referenced. I think the N-acetylcysteine. You talked about a small study where there was some significant positive improvements from injections. Just aware, I think that's an over-the-counter supplement.
Yeah, and the research was more powerful in terms of the nasal or the IV. So the actual supplements, aren't as powerful as, but obviously IV and nasal drops are much more, invasive, I suppose you could say.
I'm just curious if you know anything about the kind of rationale as to the mechanism of action, and if there's any downsides for us, whilst we might be waiting for further research to emerge.
In that particular supplement or in general?
That's that particular supplement.
Well, I mean, to be honest, I'm not, you know, a nutrition researcher or, you know, a neurological researcher behind the mechanisms of it. I suppose as a dietitian, we just have to look at the evidence and see, is there enough evidence to prove that it is safe for you to take? So I couldn't really answer in terms of the specific mechanisms, to be honest. What is really important is, you know, there's a lot of people out there who will sell, you know, I think if they're selling supplements on the back of their advice, you have to be buyer beware. Are they selling you the supplements, or are they, you know, advising you? As registered dietitians, we're not allowed to sell supplements because that's kind of conflict of interest. But I know that doesn't answer your specific question about the mechanisms, but there isn't enough evidence to say, yes, take N-acetyl in terms of a supplement form.
Okay, thank you.
Okay, as the next question is being lined up, I'm going to ask the most popular online question. So for everyone online, you can upvote the questions by clicking the thumbs up. So many people with Parkinson's report symptoms or problems with constipation, perhaps due to the medication or other reasons. What do you recommend to counteract this symptom?
So in terms of constipation, obviously the first line, even if you don't have Parkinson's or constipation, is your diet. So the core thing is making sure that you have enough fibre. So you need to have 30 to 35 grams of fibre a day, and most people don't reach that. So the average in the UK is, and in Ireland is, you know, near to sort of 20 grams, 25 grams a day. So that's really important. And also in terms of the type of fibre, so the quality and the quantity. So you need a mixture of soluble fibre, which comes from things like your fruit and vegetables and your pulses and your porridge. That gives a kind of a gel consistency to the stool. And then you've got the insoluble fibre, which is kind of nature's natural broomstick, which is the kind of fibre, you know, in whole grains and whole grain cereals, whole grain pastas, whole grain rices, etc. So the combination of those two together help to move the bowel. They stimulate the bowel to move as well. But you also need to make sure you've got plenty of fluid. And people with Parkinson's tend to not drink. Their signal for hydrating is kind of a bit dulled, so they often don't take enough fluid. So if you take a lot of fibre and you take enough fluid, that can actually worsen your constipation. So obviously that's the kind of cornerstone in terms of managing the constipation. You can also use things like flax seeds or linseeds, whole or milled, and they're shown to help, you know, move the bowel as well. But again, you need to make sure that you take a large pint of water with that, and that you build up the amount of flax seeds that you take over a period of time, because again, it can actually worsen constipation. And in terms of, you know, a lot of times people are kind of concerned around taking laxatives, but what I would say is that it's really important, if the natural means is not working, to actually not to be afraid of taking laxatives. And in fact, there are some laxatives that potentially, they don't know whether it's improving the symptoms, because obviously it's helping the constipation. But for instance, in King's College London, there's a research team that Sylvia Dobbs and her husband did a paper where they used a particular laxative in the research, and it actually showed that it reduced rigidity 4% year on year when they were taking that particular laxative. So it seemed to have a benefit, and they don't know whether it was microbiome led or because of the improving the constipation. So what I would say is not to be afraid to take laxatives as part of your treatment for constipation. The other thing that sometimes can be beneficial is tummy massage as well, and also, you know, to be aware with you know, constipation, it can take longer, so the bowel kind of slows. So, you know, you might have to sit on the toilet a bit longer, and so sometimes people might actually get off the toilet before you know, the stool is ready to pass. So just to be patient. And I suppose the other thing is, sometimes people think that they don't have constipation and they have more diarrhea, but often it's what we call overflow diarrhea. So in other words, they are constipated, and it's basically diarrhea that's kind of going around the stool. So you sometimes need to get that released with an enema to solve that constipation. So it's a big area in terms of constipation. Also, some people get what they call pelvic floor dyssynergia. So that's basically where the muscles are kind of out of sync between the anus and the large bowel and the pelvic floor. And usually symptoms of that are things like straining a lot, or incomplete movement of the bowel. And so there are some people with Parkinson's who have to manually evacuate their bowel. So if you're doing that, you need to kind of get in touch with your neurologist and tell them that you're doing that. I mean, it might be embarrassing, but it's something that can actually be helped. And constipation can be a very debilitating and upsetting symptom of Parkinson's. So will you answer that?
Yeah, very thoroughly. Excellent. Yeah. Any more questions from the floor? Yeah. We've got 45 online, so we're not going to get through all of them. But there's some really good ones we'll get to.
Thank you. Great talk today. Thank you, Richelle. I have loads of questions, but I'll have to stick to one because there's lots online. So following on from the constipation, I must say exercise has to come in there as well.
Yes, sorry, I should have mentioned exercise, very important, because your bowel, like, I think if they, wrapped it around they could wrap it around a rugby pitch, it's so big, so it needs to have exercise. So keeping moving is really important as well, yes.
Yeah, so I should qualify that with being a physiotherapist. And my question actually follows on from that. As a physiotherapist, we find we're pushing exercise all the time, and we're asking people to take that up as a lifestyle change, and a new behavioural change for people who maybe haven't embraced exercise before. And you're looking to do the same thing really here with diet. I just wondered, what are your top tips for people to make those changes? Because we all love turning to our favourite foods and our comfort foods and things like that. What are your tips to making those modifications that will last?
Yeah, well, I think as a dietitian, we'd always be looking for, what is the biggest problem for you, that you want to solve, and what is your goal? Because if you don't have that sort of aim for what you want to improve on, I think that's really important. I think as well, when you're making changes to diet, a lot of people kind of think, oh, I'm just going to change the Mediterranean diet, I'm going to do all the changes in one go, and that's just going to set you up for failure. So we generally sort of advise people to pick, 3 things, work on one, build that in. And I think in terms of also getting feedback, one thing that I find really useful is using a sort of food symptom diaries, in particular around Parkinson's, looking at what you're eating, what your symptoms are like, what exercise you're doing, what stress, what your sleep is like, because they all impact. So if you don't sleep well, you're not going to eat well. Because when you're like tired, you're, looking for, foods that are less, healthy for you. And also to understand in terms of when you're making the changes, is it making a difference to your symptoms? So that obviously, drives adherence to making change when you can see, well, actually my symptoms are getting better because I've improved my constipation. So that, makes it easier then to stick with it. So there needs to be kind of a feedback that it's working, I think is an important part. I think the other thing is, in terms, again, when you do something like a food diary, is looking at what we call your triggers. So when do you notice that, for example, you tend to crave sugary foods? And is it when you're coming off your levodopa dose? So obviously we know with levodopa, it's replacing your dopamine. And so when you're off, that sort of can almost, that fatigue, that everything, can drive you to want to eat to replace, to boost your dopamine. So it's kind of having awareness of that fluctuation and plugging in advance healthier options to kind of help with that craving sensation. So I think it is about self-empowerment by understanding yourself, that you can actually make changes that will work. So those would be some of my kind of top tips.
Great, thank you. Over here? Or there, yeah. Whoever's closest, maybe go over there. Ladies first.
I understood that one shouldn't take milk with levodopa. I understood that. But I'm still quite confused about dairy. And I think one of the slides you showed had a sort of arrow down and an arrow up.
Yes.
And so I'm quite confused. I mean, one thing I have for breakfast is a great dose of kefir yogurt.
Yes.
In the belief that it's good for me. But is it?
Yeah, so there is some evidence around what they call prebiotic sort of foods, and kefir would be one of them. But other foods that are prebiotic are things like onion, leek, garlic, whole grain breads. So actually, following a more sort of Mediterranean style diet is kind of naturally have prebiotic fibres in it, so you don't necessarily need to go and buy expensive kefir products at the moment. However, there is a lot of research going on in that area to look at specific, supplements, supplemental drinks that might have kefir in, but there isn't enough evidence in Parkinson's to say that
But it isn't actually, it isn't actually bad for you to have.
No, it's not bad for you. What I would say in terms, again, around the dairy, so the slide, and it is confusing. I would agree with you. It's very conflicting, the evidence around dairy, you know, but the very important point is it's association. It's not causative in terms of the link between dairy and risk of Parkinson's. There's no evidence to show that it impacts progression of Parkinson's. But, you know, that study did show that for an increase in 200 milligrams of dairy in a day, that it showed that it increased your risk of Parkinson's. That's not when you have Parkinson's, when, you know, before you get it. But on the flip side, it actually showed that it decreased your risk of declining cognitive health. So it improves, so dairy improves. And obviously in Parkinson's, we want to keep our cognitive side. So there's kind of conflicting message there. And I think we haven't got to the bottom of what it is, but the message is you do not have to cut out dairy. But what I would say is the advice on the Mediterranean diet, it is moderate amounts of dairy, which is 2 portions a day of dairy and only 1 to 2 servings of cheese a week. So that's the big whammy for a lot of people in Ireland and the UK is we like our cheese. So.
Great.
Thank you very much.
Okay.
Thank you very much for all the information that you've been telling us today. I'm right here.
Oh, sorry.
But I got something which is a bit hard to understand with regarding the protein intake and the absorption of the lipodova. You recommend, or you slices recommended that 45 to 60 gram we take in the night instead of taking during the day. How does that work together with the common knowledge that the body can only absorb 30 gram of protein at a time?
Yeah, so it's really interesting. In terms of that 45, that was based on a woman who was, I think, 55 kg. It's obviously going to be different for a man who's 80 kg. If it was 1 gram per kg, that's 80 grams would be his total protein in the day. But, and it's very interesting, I was actually talking at a symposium in Ireland and there was an expert in protein metabolism. I don't remember the university he was from. And I asked him about that. I said, you know, if we have this protein redistribution diet, does that impact in terms of the uptake of amino acids in terms, because the advice would be, you know, take it in pulsatile across the day, as you say, 30 grams. But he said actually the research is not actually stacking up to prove that that is definitely the case. And that actually as long as you take enough protein in the day, that that you should be able to absorb it. So it's something that I said to him I want to go back and you know, sort of go through with him in more detail. The other thing is there's a study in, I came across in Luxembourg, where they actually looked at different profiles of amino acids in different foods, and it showed that there are certain amino acids that, you know, compete for the absorption of levodopa, the blood-brain barrier, but actually there's some that actually help absorption of levodopa. And in particular, they were advising a serine-based diet. So that is, and the serine sort of rich foods are things like soya and pulses, which interestingly enough are a big part of the MIND diet. So this is where I think the research needs to get into the, you know, what is it in the foods that actually is, you know, showing, because the MIND and the Mediterranean diet are the diets at the moment that are showing the most indication of potentially affecting progression of Parkinson's.
Yeah. Just the last question about the MIND diet and the Mediterranean diet, which one is the most recommendable?
So they're both, I mean, at the moment, you know, any sort of Mediterranean style diet, but as I said before, you know, probably the MIND diet is a neck ahead in terms of being showing sort of more impact, but we need more randomized controlled trials, and they are expensive to run. I was talking to a researcher who did it in diabetes. She said it cost 2 million to run it, because you have to actually, with a diet trial, you need to actually have the foods and buy them for, you know, to make sure people are sticking to the diet, so you can actually prove, you know, versus a control arm that it's actually working. So there's a lot of cost associated with it. But we need more research, because at the end of the day, there's no drug that actually, you know, is disease modifying. But in exercise and diet, we're seeing signals of disease modifying, but we're not getting the funding to do it.
Thank you very much.
Okay.
Great point. I'm going to ask a few online while the in-person are geared up. So Becca YOPD is asking, are there any particular foods associated with negative effects of PD?
So I know Becca, she's fantastic from the States. Becca, so in terms of negative, the biggest negative is actually the Western diet. So processed foods, you know, so again in the Mediterranean diet, it'd be advising to keep your red meat, you know, to twice a week. And again, in terms of portions would be small, you know, in terms of, you know, takeaway foods, keeping that, you know, to a maximum of 3 a month and ideally once a month. So your takeaways, you know, in terms of treat foods, keeping it to less than, you know, 4 servings of treat foods a week. And a serving is only about 100 to 150 calories. So that would be a can of Coke and a bar of chocolate, and that's your fill for the week. We know in terms of people who have diabetes who don't have their blood sugars under control, their Parkinson's symptoms tend to not be as well controlled. So, yeah, so I think really, as I kind of showed in terms of people who had a better score in terms of followed Mediterranean diet more closely, had better outcomes. And I think you know, the scores were low in people in Parkinson's. So that's where I think low-hanging fruit is start, you know, following more healthy diet and, you know, reducing the more ultra-processed foods.
So next question is quite popular for some reason. Have you heard about lion's mane mushroom, which is used in the Far East? Does it to slow progression of Parkinson's?
Yeah.
Parkinson's, is it safe?
So what I would say about it is kind of the what do you call it? Not supplement du jour at the moment. It seems to be coming up a lot. But in terms of research I've looked at, it seems to be that it is acts as an antioxidant and might be having an anti-inflammatory impact. But when I tried to find, you know, research trial with it, it was really hard to find something that actually, so, you know, it can interact with sort of blood thinners. And so I think, again, if you're considering taking any of these sort of more alternative, you need to let your neurologist know so that there's no kind of, or your doctor, your geriatrician, that's not going to interfere with any of your medication. But at the moment, I can't say that there's any benefit. I mean, the one thing I would say, though, is a lot of the time in these kind of supplements, no one's going to fund a trial in it. So does that mean it doesn't work? I don't know.
Often the jury's out.
Yeah.
Any more in-person questions? Here?
I'd like to hear about coffee.
Yes.
That was also an online question, so good question.
Yeah, so in terms of coffee, it's kind of a bit like dairy. There seems to be, like, every time I read a paper, it's like, yes, it, you know, improves Parkinson's. And the next one I read is, no, it's bad for Parkinson's. So I think, again, we haven't got enough evidence to say one way or the other. What I would say in terms of coffee is that, you know, the guidelines are to stick to roughly 300 milligrams of caffeine a day in general, and that's, you know, 3 cups of instant coffee or 1, you know, really good coffee in a day. So with caffeine, it can stimulate restlessness. It can create tremor. If you even don't have Parkinson's, it can cause tremor. It can cause gastritis, and that can cause problems in terms of medication absorption. So it's just like, keep it in moderation. For some people, actually can help their constipation. It can move the bowel for some people, and in some cases it's been shown that it can help levodopa absorption, possibly because of that. So I don't think it's a case of you have to cut out coffee, but it wouldn't be something, you know, that I would advise someone who is not a coffee drinker to suddenly start drinking coffee, because sometimes it can be dehydrating. If you're a habitual coffee drinker, generally it doesn't dehydrate you the same extent as if you were someone who suddenly started drinking coffee. The other thing about coffee is it can stay in your system for 8 hours. So if you take it before bed and you have sleep issues, you know, it can keep you awake. So it's a stimulant at the end of the day. Okay.
So, Dr. Why is it not prescribed alongside diet as a matter of course?
Well, what I would say is, why isn't diet prescribed alongside exercise at the moment? Because all I hear is about exercise of Parkinson's, which I absolutely 150% agree with. But I think, as I sort of showed in one of the slides, the combination of the two is probably the most powerful impact. But, you know, in terms of our physio colleagues, they can't get access to a dietitian to, you know, to help advise on that, you know. And then also in terms of, it's down to that individual. So if you are, you know, a woman who is, you know, underweight, dyskinetic, you know, has diabetes, there's a whole kind of mixture there that you have to actually tailor the diet to that person in front of you, who's going to be different to a young onset, you know, man who's doing marathons, who, you know, has to take more, you know, calorie requirements, and you have to moderate their protein around their medication intake and make sure they're getting enough carbohydrates in. And, you know, so it's a very individual thing. And obviously with DBS, that has its own, you know, needs.
Any more questions? Oh, yeah, in person right there.
We often hear that in the morning we should eat like a king.
Yes.
And then in the evening, eat like a pauper.
Yes.
So what importance would you attach to regular meal times?
I think, you know...
rather than skipping and
yes.
or deferring
yeah.
you know, lunch and so on.
Yeah.
And in terms of the portions that are served throughout the day,
yeah.
should they be relatively consistent?
Yeah, in general, like even without Parkinson's, we'd sort of advise that people sort of have a consistent meal pattern. And also it's important for the bowel function as well, you know, that you're not starving the bowel and then loading the bowel. Also in terms of blood sugar control, it's kind of getting that consistent blood sugar rather than sort of having big, you know, dips and spikes. What I would say in terms of Parkinson's is very important around the timing of your meds to your meals. So if you keep on moving your meals, then you might end up moving your meds, and so everything kind of gets out of whack. And I do think we need more research around the timing of meds, and because the reality is, like I know in Ireland, some people don't see a neurologist for 3 years, and they end up then popping pills themselves to try and counter, and that can have issues associated as well. And then also in terms of people, if they're moving their, especially if you're on sort of 6 or 8 you know, doses of levodopa a day and you're trying to time, as I say, your meals around it, that can be very difficult. So in terms of, you know, breakfast like a king, what I would say there is there's often a thing called akinesia in the morning, where people find it hard to just switch on in the morning. And so part of that could be that they're eating, you know, too large a protein-based breakfast in the morning. But also what I often find is that a lot of people have no medication overnight. So they have the last levodopa at 5 o'clock in the evening. So they have nothing. And so it's not entirely surprising that they're not able to move as well in the morning. So I think sort of diet, exercise and medications, they kind of need to all, they shouldn't work in isolation. I don't know if that answers your question, but consistency, I think, is very important.
Okay, a brief one online. Any advice to reduce stomach bloating?
Yeah, so people, again, with Parkinson's, bloating is a big issue. So I mentioned about Helicobacter pylori and SIBO in particular can cause bloating symptoms. And, you know, in terms of that overgrowth of bacteria, it can also be that, for example, that you might have celiac disease that can cause bloating. You know, so there are a number of potential causes. It could be that you have irritable bowel syndrome. So it needs to kind of investigation if it's an ongoing problem to see what's at the root of it, because it can be very, it can cause problems with your eating, and so people lose weight. The other thing then is gastroparesis as well. So basically in terms of the stomach not emptying, so people kind of have a sense of bloating. They feel they get full quickly as they eat their foods. They find that they can't eat solid foods as much. And I've actually spoken to quite a lot of people who've, you know, self-selected stop eating. They don't realize why, and it's often because their stomach's not emptying. And so that has that fullness, bloated feeling. That really has to be dealt with. And just to say on that, if there's any time that a Mediterranean diet is not appropriate is when you have gastroparesis, because in terms of the high fiber element of it, because when you take a high fiber diet, it slows your stomach emptying down. So if you have slow, it's going to make it worse. So in those cases, you would need a low fibre diet, a low fat diet, and maybe more a liquidized diet. But there are medications that can help in terms of speeding up your gastric emptying as well. So again, that's where you really need a gastroenterologist to kind of deal with that. And if you have that, that can really cause a lot of offs in terms of when your medication doesn't turn on. People can't understand why. That can be one of the causes.
Any more questions from the audience here? I can go to the next online one while you're thinking. Does the importance of diet and nutrition get more important as Parkinson's progresses?
I don't think so. I think, you know, one of the reasons, so I hid my Parkinson's for the first 2 years because I didn't have a tremor, so I was able to hide it. But, you know, I decided when I went to the World Parkinson's Congress, I thought I did a lot of advocating for other conditions, my celiac disease, for example. But I felt sort of stigma. I thought my colleagues would think I was lesser than. I thought patients might think I wouldn't be as capable. When I went to the WPC, I thought, okay, I need to actually get over that and start advocating. But the reason I'm saying this is that actually we had a sort of self-employed dietitian WhatsApp group, and one of them put in the WhatsApp group, do any of you see young onset patients? I only see them when they're more advanced. And I thought, okay, I have to say something here, because I think diet is very important no matter what age or stage of the condition. Each stage has needs with regard to nutritional care. Obviously, getting to more advanced stages is really important in terms of, you know, managing things like, and sarcopenia can happen across the board, but I suppose in terms of more intractable issues around gastroparesis and more, I suppose, palliative issues with regard to eating and, you know, so tube feeding and various different things that might be required. But I think it's important across the board.
Yeah, I think that's important to say from the very beginning. I think diet is really important. Yeah.
And it's just one thing to say with regard to dysphagia. A lot of people, you know, when they're first diagnosed, they don't want to think that they have swallow problems. But when I was diagnosed first, in the first couple of years, I noticed I had this problem with sort of always clearing my throat. And I thought, I wonder, is this to Parkinson's? And I spent a fortune, you know, on scopes and tests and whatever. I kept on saying, I think maybe it's Parkinson's. And they were like, no. And I basically pestered. I went to the World Parkinson's Congress in Kyoto, and the speech and language pathologist there said everyone with Parkinson's should get a speech language video fluoroscopy at baseline. And that basically tests your swallow function. So I went back and pestered the speech and language therapist, and eventually they did it. And then on the day, they kind of said, no, everything looks fine. And I felt really guilty that I had pushed it. But when I went back into her to have the report, she said, actually, there was a problem, you know, and I was only sort of 48 or 9 at the time. And she said, do you have the swallow of a 65-year-old? So I do have dysphagia. I don't, you know, choke on my foods or don't. But the important message with Parkinson's, like exercise, is your muscles are affected everywhere in your body. And the earlier you get in, the more you're likely to prevent that sort of getting worse for as long as you can. So that is definitely a message I would say to people, is you should be asking for a test of your swallow. And also often people don't realise things like drooling is sometimes an indication that you have a swallow problem, because the saliva is coming out rather than being swallowed. So and that can be really, it's one of the biggest killers of people with Parkinson's is aspiration pneumonia. And one of the biggest causes of aspiration pneumonia is dysphagia. So yeah, that's another thing I'd say.
Yeah, excellent. One more question?
I think we had one over. We've got time for two?
2 more questions, yeah, sure. Yeah.
I was just wondering about the supplementation. You talked about like folic acid and iron and calcium. Should you try and get them from the diet, or should you supplement with them as well?
Yeah, so what I would say in terms of the calcium and the vitamin D is, I mean, vitamin D, you know, obviously get from the sunshine, but obviously you're putting lots of cream on that blocks that. So most people, you know, need to have vitamin D supplementation in the winter times anyway, but, you know, over the age of 65 year round. In terms of the calcium, again, if you're following, say, the Mediterranean style diet and you're only taking 2 portions a day, it's not going to get your calcium requirements in, but you can get it from other foods in the diet. So, but that's again where a dietitian would analyse your diet and actually see, you know, are you struggling to meet it through food? And that's when you would supplement maybe with a 500 milligram supplement of calcium. And in terms of folic acid, again, you can get that from your green leafy veg, but if you like boil a broccoli, you lose 80% of that folic acid. And the thing is with folic acid, if you supplement with folic acid, you can mask a vitamin B12 deficiency. So you kind of have to make sure that the blood tests are checked. In terms of iron, one thing I sort of recommend to people is to check their ferritin levels. So often, you know, their iron can be normal, but their ferritin is the thing that's dropping, and that can be a sign of you know, behind the fatigue. So that would be something I'd check as well.
Thank you.
Okay.
Thank you. One more question. Have a look at, so she will read them all, but you won't be able to answer them all. Thank you. Brendan, please.
There's obviously a shortage of Parkinson's nurses, and trying to get advice from nurses is proving to be quite challenging. It's obvious, therefore, that there's an even greater shortage of dietitians who've got experience with Parkinson's. Mm-hmm. So is there a source of genetic information that we can tap into?
So in terms of, I know Parkinson's UK have a diet booklet. We have developed a sort of quite a tailored one for the Irish Nutrition Dietetic Institute for Parkinson's Ireland. There are like good resources on, you know, the likes of the Parkinson's Foundation in the US websites, Brian Grant Foundation. So there's kind of generic information that you can kind of get access to that would help in the interim. But one area I'm sort of working on is to try and develop resources for people with Parkinson's in terms of access to online nutrition programs that they can learn from, because basically it's going to take us a long time to get enough dietitians trained to get you the information. But that's coming.
Can I just add that this lecture is going to be an online resource for just that as well. So we'll distribute the information in this lecture to as many people as we can.
Yeah, and the other thing as well is so I did a talk at the WBC for young onset Parkinson's around nutrition and diet, and they're having they're doing an online series of webinars replicating what we did for people with YOPD in WPC in December. A lot of what I sort of talk about there is applicable, you know, for people of all ages with Parkinson's as well. So that you could sign up in that in December as well. And also you can Google, there's a number of talks I've done, and there are a few American dietitians who've done talks online as well. I have a YouTube channel, My Moves Matter YouTube channel, and I'm trying to put up some of these talks that, you know, that are evidence-based that you can access as well.
Great, thank you. I'm going to ask James to make the closing remarks. Is that right? Yeah, thank you.
Thank you, David. This is more a commentary for people online, because those of you in the room will have seen this, but rarely have I seen people reach for their pads and pens as quickly as when we discussed red wine and the potential benefits of that. I mean, it was quite remarkable, and I was going to only mention that, but it's now been outranked by your response to the suggestion that cheese might be an issue, which caused such an intake of breath I could feel the wind pass by the side of my face. It was as if any of you were here 2 years ago with Julie Jones talking about physical activity in Parkinson's. It was as though Julie had said, by the way, you need to run a marathon a week. It felt like that shocking a news about cheese, but thank you for being so honest with us. So my name's James Jockley. I'm the Scotland Director at Parkinson's UK. Parkinson's UK, many of you will know, but we really do three key things. One is we fund research. The other is we work alongside the NHS in the UK to try and improve the care and support for people with Parkinson's. And the third is about providing information, advice and support and working with communities up and down Scotland and the rest of the UK. And it was in one of those settings where probably I first came across the issue of diet and Parkinson's, but in a very specific way. I was at the Young Onset group in Edinburgh, and they meet for a meal before they have their meeting, and it's in a function room adjacent to a pub. And I can't tell you what they were mostly eating, Richelle, because it's too shaming now, and I can't possibly admit it. But there were a number of dishes available. And I was discussing with the group about how important it was to come together and share time with a community of other people affected. And I noted the fact that they were having a meal first. And I said, oh, and it must be nice for you to have a meal together with other people. And one of the people leant towards me quite conspiratorially and went, the thing is, we can have peas. And all he meant was that he felt safe amongst other people with Parkinson's with his tremor, that eating peas was a safe thing to do within that group of people. I don't think he was making it dietarily, he was making it purely practically. But from that point onwards, I realized how important these decisions were. It's my kind of pleasure to do this closing address. I feel kind of underpowered to do it because the last 2 years, many of you know that Dr. Alison Williams has done that, and I don't think I can do her justice, but I will do my very best. Some of you will have heard of Maggie Keswick-Jenks, who set up Maggie's Centres, the first of which was set up in Edinburgh. And she often described a cancer diagnosis as being a bit like being dropped out of a plane behind enemy lines, but with no map of how to get home. Now, some of that has always struck me as true for Parkinson's diagnosis and living with a condition too, but I'd probably add in being blindfolded and spun around 3 times before you're set on your way. And I think what Richelle has highlighted so powerfully this evening is another area of that Parkinson's map that so many people with the condition find challenging. So how nutrition and diet can enable you to live as best as you can with the condition. Now, as we've touched on earlier, many of you will know the impact of Parkinson's on eating, swallowing, constipation, that thorny issue of protein and levodopa. Now, some of the rest of you will know about the links between the gut and Parkinson's. But I think what Richelle has particularly helped us navigate are some of the challenges and opportunities there are for this much more proactive consideration of dietary changes and how they can benefit people with Parkinson's. And as Richelle has pointed out, and we touched on there in the Q&A just at the end, there are a whole range of specialisms that as a charity we would love to ensure that people with Parkinson's had more regular access to, dietitians being just one of those. And I guess as well, I'm left reflecting this evening on just how much more there is for us to understand. But also, at this lecture, on every other lecture that some of you will have been to, there are brilliant minds at work doing work right now to help the community of people with Parkinson's make good choices so that you can live the best lives you can, despite everything that Parkinson's is throwing at you. Now, do we understand enough about diet and Parkinson's? I think we can conclude from today almost certainly not. Is there a right and wrong? And I'm choosing to reference Julie Jones again here when she talked about physical activity. Feels to me what's key is about finding what's right for you and what the evidence supports. Is Parkinson's a whole body condition that debilitates people with it and fascinates people researching and trying to understand it? Absolutely yes. And I think one of the privileges for me tonight is to hear from Richelle, who's both challenged by the condition but working so hard to try and find ways that we can encourage people to live better with it. So whilst we still feels to me like we're stuck behind those enemy lines, I do feel after tonight we've got a lot more help in helping navigate each of us back through them. Thank you.
Thank you, James. Could I have my vote of thanks slide up? Thank you. Before the vote of thanks, we're looking for some money to fund future Parkinson's lectures. There'll be a collection as you leave the lecture theatre, casual card accepted. And if you're watching online, there's a link at the very top of the web page, not on the slide, but on the top of the web page. If you click on that, you could make a donation to support Parkinson's research as well, if you'd like to do so. So as far as the votes of thanks are concerned, I'd like to thank Dr. Alison Williams again for giving such an eloquent introduction to Richelle's lecture. Tilo for the juggling of the Q&As as usual. And James and more importantly, all of the Parkinson's UK staff, James is nodding, for all the help that they give us to organise the lecture and help with the management on the day. The lecture is funded by the Edinburgh branch of Parkinson's UK, so very grateful to them, and also to the team here at the Royal College for putting the slides and everything on so efficiently. Finally, I'd like to thank Richelle. Richelle, you haven't just given us food for thought, you've given us food for all the other brain and bodily functions which are affected by Parkinson's. And for that, we'd like to thank you very much. Thank you. Thanks to everyone for watching, both here and at home. And for those watching here, have a safe trip back home. Thank you.